If I can stop a patient falling and breaking their hip this afternoon by a simple intervention, such as an app tells me to read a policy about falls because that ward is known for falls, and I read that policy, as a result of which I take an action that reduces the risk of the fall, and the fall doesn't happen, I've saved literally hours and hours and hours of admin time and clinical time generating an incident report, doing a review, presenting the findings, let alone the patient who's had a broken hip.
Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Hello there and welcome to The Connection podcast with myself, Darren Kilroy, Medical Director at RLDatix.
Oh, and me, Liz Jones.
You're very welcome. Thanks for joining us. We're currently at the Patient Safety Congress here in Manchester, where for once it's not raining, though it's always threatening. And it's really interesting to be at the conference this year because there's so much going on. And we thought we would talk a little bit about what's been happening in the past week or two in terms of productivity and how that then fits into patient safety, which is where we are today.
So we've had the 10-year plan. Everyone's been there was the flurry of excitement with everybody taking the document and turning it into another form of a document.
A flurry of excitement, people. A flurry of excitement is absolutely what it is. But you're right, though. There's been loads going on.
Yeah.
And it's sort of to the point where you're sort of wondering where you catch up on it all in a way. That's what I've been thinking. Where do you begin to make sense of what's happening at the moment and then prioritise? Which is a really great position to be in. But you're right, it's been busy.
I think, so last week we were at an event, we and some colleagues were at an event in London with the HFMA, that's the Healthcare Financial Managers Association.
Yeah.
It's a bit of a mouthful.
So that's why it's different.
But we were there and we were talking about, or you in particular were doing a presentation on productivity, and we did a soft launch of a piece of work that you've been doing with NHS England, and we'll talk about that in a minute. But I was really struck by the fact that there is this permanent disconnect between the kind of policy conversations and then when you chat to somebody who's just trying to get the job done. And I know you talk about this a lot. So maybe by way of getting into that, it felt really healthy to be at an event with real people who are just trying to get their jobs done.
Yeah.
And it brings you back down to earth, doesn't it, in terms of how all this stuff is going to actually pan out.
Yeah, it really does. And actually, just a little bit of explanation of context to clumsily get to a really important point, I think, here. By virtue of agenda swaps, my session was swapped with a really great session from Nikki Briggs, who's the Deputy CFO from NHS England. And that being the case, she started the day, and I was going to start the day, and that worked out really well without us even having to try. Because she gave such a brilliant presentation, didn't she, around where things sit in a really hard-hitting way, in the way that finance people do, around the reality of what money's gone into systems and where, in financial terms alone, to be fair, improvements have or have not been manifest.
Yeah, absolutely. And you're right, it was really hard-hitting. It was, it was data-driven. It would be, it was finance, isn't it? Right. But it wasn't just finance data, it was clinical data, it was performance data. But I tell you what's interesting, Darren, I think over the course of the last couple of weeks, that will be the third one I've been to. The other two have been Chatham House, so I can't quote the speakers, but I've sat there and thought, wow, times are different, right? And there's a lot of kind of like, we've been through change before, but start of the 10-year plan, do or die. And I guess people are saying, we say do, aren't they?
Yeah.
That's what's going on.
Yeah.
And it does feel like it's quite profound, the pressure to change.
Yeah, it is. And what I really liked about Nikki's presentation, I told her so afterwards, in terms of the power of why we need to change it and the immediacy of the proposition now, was that she presented all the national data And around all that, she brought it right down to particular individual patients' case studies around where they are now on their packages of care. And the human element of that was really interesting.
I thought that was, you're right, and I thought it was really interesting. I think it was the only time I'd ever seen somebody or heard somebody in finance make really straightforward comments about where and how care is delivered.
Yeah.
So in particular, she called out around the outpatient follow-up appointments and how many of those are happening versus, for example, perhaps we could get more balance with primary care access. I think was the example she used. What's your thoughts on that in terms of finance people talking about clinical modes of care delivery?
Yeah, I think it's really good. And it's not loads of any financial colleagues listening to our podcast and people we, of course, loads of financial people in healthcare are really interested in care and human beings, because we're mostly users of the system when we've got relatives and loved ones who are. But in the day job, of course, you're compressed into talking about data and figures because you've not got much time to get through the stuff and there's loads to get through. And one thing about events like that and her presentation, that the ability to have a bit of time to humanize it was important. But on your point around outpatient follow-ups, it gave me a wry smile when she was talking about that, because how many meetings did I sit through in my NHS days where you were trying to belabor the point of eliminating outpatient follow-ups for all but the most necessary cases, because they are an expensive use of resources. And I myself remember in many years as a junior doc because usually the junior staff in any team are given the job of the follow-ups and the consultant sees the news to plan the care. And how many clinics did I sit through seeing loads and loads of follow-up patients who come many miles to sit in a room to be looked at by me, a rookie medic, to just say, looks like you're doing okay, Bob. We'll see you in a year. And off they went together. A day out of their lives. Easy work for me, but difficult for them to get there and back for literally 5 minutes of clinical time.
Is that going to be, because this is the intersection between, which is what we want to talk about today, isn't it? The intersection between, I guess, financial pressure, productivity, which is different, and then actually, because we're here, risk and patient safety.
Exactly.
And so what you've described there from your days in practice, as a rookie, as a novice, as a nothing, as nobody.
Folks, if you see Liz in the clinic anytime soon, don't have an appointment.
She's a late starter.
Exactly. Check that badge carefully.
No, but as somebody who's a lay person, that was the phrase I was looking for. That makes sense what you say. And then I think to myself, well, but aren't people going to be much more complicated in the care that's been delivered in the future and the settings in which it's been delivered? And therefore, isn't the role of outpatients just about to be tipped on its head in terms of what it does?
It is, because...
So how do we safeguard the balance between...
Yeah, you're totally right, because the whole concept of repeat outpatient follow-ups, I remember a very quick 10-second anecdote. I once worked for an ENT surgeon who used to get patients into his follow-up clinic because it was easy work, and he used to say to them, Mr. Smith, you or I will see each other until one of us dies. Because he brought all these patients, brought all these people back to outpatients.
And also,
because it was risk, because it was seen as risk mitigation, because it's all about risk behaviours, because by seeing them once a year, there was a thought process, wrongly, which I can see it at the time, that was managing risk, because you were keeping contact with someone. And of course, this is in the days before ambient technology was there and tools that we've now got which make that redundant. Because you're absolutely right. If the net complexity of care is rising, then that is exactly where you need ambient technology and home-based tech to come into the fore. So you can follow more parameters that the patient has wrong with them remotely and intervene in a targeted fashion using primary care rather than dragging people into clinics just to say that everything's all right. So it is changing times.
It is changing times. And so fundamentally, it's the model of care that's actually changing.
And it's evolving, it has evolved. And although there are definitely productivity problems with how we manage outpatients, for instance, in the acute provider environment, loads of stuff has changed. And there's brilliant improvements that have occurred around managing old people, complex care, young people with complex care needs, neurodiversity in teenagers, long-term management of aspirin epilepsy in teenagers, which is really tricky. All these things, ambient technology and home-based care is the norm, My good friend Rahul Chadari, who's worked with us on the productivity paper, he's a paediatrician, but he's not working for NHS England, and his speciality is around respiratory conditions, and he uses loads of home-based and ambient technology in managing saturation levels and other things in the most difficult respiratory cases in children. So there's lots going on. But yeah, of course, a lot of these things, although on the face of it, and this leads into productivity for us, although on the face of it, you think, people are at home having things strapped to their wrist and stuff, that's all quite cheap and it's quite easy. Lots of that is really quite expensive to run.
Oh, yeah.
And the staff required to do the monitoring and to do the intervention are still staff on rosters and
Of course, yeah.
job plans. So it doesn't follow that you are reducing cost necessarily by making more things virtual. It's just changing locations which are better suited to patients, but doesn't necessarily lead to a reduction in cost.
No, well, it's unproven, isn't it? And but the other part of this is that there's got to be a change in profile in terms of risk, because if you're doing that in the home, there's this other equation that of people that, whether or not it's family members or other, that presumably are part of that equation with the equipment and so on and so forth.
Exactly.
But going back to what I wanted to talk about in particular. So last week we were at the productivity event. Yep. As you rightly said, you followed the incredible presentation, very frank and impactful presentation from Nikki, and shared some of the work that you've been doing, which is a paper that's been launched this week.
Yeah.
So just talk us through what that paper is, and then I've got some particular questions I want to ask you about it in relation to patient safety, actually.
Yeah, exactly. So the paper is essentially, it's been a collaborative piece of work between ourselves and some of the productivity team at NHS England, looking at, in particular, the job plans of our most senior clinicians in the NHS.
And so for anybody who's not aware of what a job plan is.
So easy. A job plan is essentially a schematic. It's a description in terms of days of the week and types of activity that go on that just basically describe what is expected to come in the working week of a clinician.
And in actual fact, I'm just thinking back, I'm pretty certain when we started the podcast, one of the very first ones we did was a group of us talking about job planning.
Yeah.
So we're not gonna do a lesson in job planning, because you can go back to that podcast.
It's available.
But there is effectively a longitudinal set of data that we've got about how this has been done over a number of years.
Over several years. And the data, it's the first time we've done a piece of work that's so large in its scale, looking at 5 or so years of activity of consultants across England using our software technology in terms of the job planning tool. And what it showed was really interesting, because it contrary to what might have been believed, it showed that some things haven't really changed much over the years, but other things have subtly changed quite significantly. For instance, there's a slight deterioration in the number of clinical sessions being worked across the land. There's a slight increase in the amount of admin time being consumed across the footprint. And there's significant changes in terms of whether you're full-time or part-time and what the disposition is of your time within the working week.
But if I'm not mistaken, looking at the data, that there was a bit of an assumption, I think, that we and others had made going into this. So, everyone knows that effectively we've got more workforce and we've got less productivity than we had pre-COVID. There was an assumption that probably some of the drop-off in productivity could be related to part-time working. Yeah. And whilst that there is an element of that, it isn't really the defining factor. So what's really going on here is that work's changed. Or is it attitude to work, or is it work has changed?
We didn't really assess. We didn't look at causation in the study. It was essentially looking at what the reality is of what the data shows us. It was very quantitative in this respect. And the quantitative data about what people are doing all day demonstrates that, because the productivity in terms of the normal way we approach productivity, looking at elective care particularly, in terms of how many operations you can get done and how many clinics you can provide, the ability of our existing workforce to provide that capacity has been nibbled away at by complexity of patients in the hospital setting, in terms of the requirement to do more ward rounds, do more diagnostic work.
Which are all things that we would be really positively encouraging.
All need to be done.
And have been encouraged for a long time.
Absolutely. Yeah. They're very necessary because of that complexity we talked about a few moments ago. But what it does do, it reduces serially the ability and the availability of people to do the other elective work that needs to be done. And on an individual practitioner basis, that's subtle. When you scale that up to a national picture, you're losing dozens and dozens of opportunities for productivity every day. Not because people aren't doing anything, but because they're doing different things that aren't easy to surface.
Basically, the job has changed a little bit, and they're doing more. So on that, and so from that, and of course, this report is available for anybody that's listening to this, and we'll make sure there's a link somewhere in there.
It's a great read, everyone. I'd absolutely encourage everyone to have a look at this. It's very readable, and it's not draped in detailed data. It's a readable paper.
It is, and I think there's two things about it, Darren, and I wanted to kind of so first thing is that obviously our data team, as it were, did the data, and there was an assumption that the data itself will reveal the story, and the reality of this is that the data revealed part of the story, and it took your expertise as a clinician to be able to say, actually, the natural next steps of inquiry are either here, there, or this is a plausible explanation. And I just wanted to just hone in on your thoughts on that, because we're in an era where people think the data is going to tell us what to do, and maybe it is. But what's your view on that in terms of data versus insights versus experience?
Well, I think that everything is data in one form or another.
True.
The data we looked at was quantitative. The insights and experience are qualitative, but they're just as valuable if you take them in the right way. So I think what it does do is the data suggests a proposition. It gives you a hypothesis. It suggests things. And obviously, it infers there's a cause. So the insight is then, well, what is the likely cause? And then importantly, what do we do next to try and do something around that?
So powerful put in. So that exact process you just talked about there, the power of bringing the data. So if you were to represent them in the context of this, that idea that we take the data and we start putting it in the hands of the people that are best suited to understand what's happening. That's got to be the way forward.
Got to be the way forward, because you need,
rather than the reveal of the answer.
Oh yeah, the best, most powerful use of data I've ever known clinically, and latterly with the exciting work we're doing now, is where you democratize it and you give people access to it, so you can then guide. Everyone's entitled to their own opinion about any piece of data, because in large part, usually they own it. But in terms of what we think about and how we do things with it, that collaborative sort of sense of collective insight is really important, because when you do that, you get people truly involved in it. Then you can make changes that actually stick. And that was one to start reality for me in the HFMA session after Nikki last week, because it was positioned fairly explicitly around job planning and productivity. And this was to a finance delegation of finance delegates, senior finance personas and figures in largely the NHS. And what was really interesting to me was they were really bought into and interested in the proposition of using job planning to improve productivity and improve cost use and efficiency. But the knowledge of how job planning could contribute to that, we've still got a ton of work to do on that. Because these are all people who work at a senior level in NHS organisations, but they need more awareness, and we need to give them more help around how they can match their expertise to the propositions, as for instance in our paper around job planning and productivity, which is really key, because most of their spend is on workforce, and we need to work collaboratively to make sure that everyone who's involved in finance and also in risk is fully sighted on the different strands that contribute to that spend being spent effectively. And that was the nub of the session for me.
That was one of the, you're right. And I think one of the things that stood out for me across the whole day, your session, Nikki's session, and the subsequent sessions, was it's going to be essential moving forward that finance people are, if they're not already, and I know there are some great examples of this, but not everywhere, but finance have to become fluent in some of the clinical language and risk and workforce. And we can see from data that quite often that there's a complete mismatch in terms of the way one would describe a budget, for example. They're misaligned. So that fluency around finance and clinical language and different teams being able to do it. So did you have training in finance? I know you did because you did an MBA, didn't you? So you would have done it then. But as part of your
No,
Did you?
I didn't, and that's a huge
And yet
omission.
you got given effectively budgets.
Yeah. Well, it's interesting, isn't it? Because you do get given budgets, and let's be honest, if something is clinically required to be done in healthcare, it usually gets over the line because the clinical voice will get it there. 'Cause it's a compelling clinical proposition usually, which can get around financial obstacles if it tries hard enough. But no, and it's long been an interest of mine to think how you get people more involved in that training while still respecting the speciality and
Yes.
profession
Yeah.
of finance or HR or clinical work. They're separate disciplines with separate training, and that's entirely right and proper.
Yeah.
But that crossover, and probably, if I'm being frank, from all my years in NHS, certainly at board level and exec level, the architecture of how the NHS sets itself up in its governance doesn't help that, because you've got a fairly explicit, usually a finance and performance track. You've got a quality and safety track. Quite right, you've got different exec accountabilities on those tracks. They come together at board level at the top. But it's not easy on that basis to have crossover between, say, workforce, risk, finance, incident management, all these things, because they're in different reporting lines. And we're in an era of change and improvement in that.
Yeah.
To sort of cross-pollinate, you might say, all those different really important propositions. And that's where I think we can do a lot of work with the portfolio that we have in RLDatix, and working collaboratively with customers and providers to think how we can make more sense of stuff.
Yeah.
And also, I think really importantly, not just generate reports showing how things were and how badly or well they went, but in real terms, like this afternoon, armed with that knowledge, what can I do proactively to improve things in any given domain? Can I make better staffing decisions this afternoon than I did this morning based on some data that's pretty live? Can I make new financial decisions based on that, the same data ideally? Can I look at where risks sit within that and translate that to something that staff on the ground can use today to reduce the likelihood of a risk being manifest? All these things are important. And I do believe that with the advent of the technology now at hand, and we've been talking about that at the event here today, there's a real chance to get that cracked.
I agree with that. So one of the things that came out the productivity report was the fact that clinicians, these are senior doctors typically with job plans. I know that we can have allied health professionals on there, but you looked at the senior doctors. There's been a reduction in the amount of time they spend on things like clinical audit, and so some of those, and actually I think education had suffered as well, right? So, and if I go back, I've known you a few years, and if I go back to when I first met you, when you were at East Cheshire Hospital, you would talk quite proudly about those pieces of work being things that had given you satisfaction at work, as well as been important work for the onward kind of development of the organisation. So we can see in the data that there's not enough time being dedicated to that. Is that right?
That's right.
Okay. And so here we are now at a conference on patient safety. So flip it. Last week we're there at productivity. Here we are at patient safety. And job plans are not a topic of conversation here, other than in this room.
Probably quite rightly.
Yes. You say that, but it is interesting because it's all this stuff. It comes together in terms of, and I was laughing because I was describing what quality is versus patient safety to someone earlier on, and I said, well, really, it's the important bit about why we're doing workforce and risk, because the bit between the two, you'd hope, is quality, and that's quality finance, quality care delivery, quality experiences for staff. So if you get quality right, then, and so actually, just give me your views in terms of why there is such a drift in the productivity conversation, why it's not a conversation about quality and patient safety.
I think because it's pretty embryonic still, to be honest. I think that we've only really had proper discussions around the importance of job planning in the past year or so. It's been on the edge of interest for a while
because it's been a compliance
activity, and who wants to enjoy compliance activity? It's one of the things in life we don't enjoy doing because it's something you feel you have to do.
So how do you think you change doctors' mindset on that? Because that's the key, isn't it?
Yeah, you change doctors' mindset on clinicians' mindsets on that. No, because you draw out of the necessary elements of it, and compliance is still a necessary element of it, in one way. You draw out of it the benefits, you articulate the benefits to the clinician of what it is to engage, the why, as I keep saying, why it's an interesting exercise to be involved in. Like, for instance, the reasons I would suggest that clinical audit, teaching and training have suffered, for want of a better expression, in the way that job plan has changed, is because on the one hand, there's more complexity in the care to be delivered and there's stuff to do and there's a big queue of patients and there's lots of risk in a queue of patients who haven't been seen, significant risk, versus the need for clinicians to properly describe and account for the things that are required to be done in terms of teaching, training, clinical audit, CPD, things that are necessary for your professional development. All these things are important because we don't want a set of clinicians who aren't professionally developed. That's dangerous. And compelling people to account for all those things is a good thing to do. But of course, when you do that properly and diligently and at scale, it surfaces a big issue, which is that there are only so many hours in the day, and we're expecting people to do more and to document that they're doing it properly, so they've got accountability for it, so you can actually manage it properly. Which then lends into itself. You could then say, we need to shuffle more workforce in them because there's more to be done. But we know that doesn't necessarily equate to better outcomes.
Yeah.
Nikki's talk showed us that.
Yeah.
So what it does then compel us to do is to think properly, and this is the moment to do it, around how we then use the technology to make the working day smarter.
Mm-hmm.
So you do less is more in a way.
Mm-hmm.
You've got the technology to enable you to spend less time worrying about reports of what happened and more time, which takes less time, looking at anticipatory actions you can take to reduce risk. Because if I kid you not, if I can stop a patient falling and breaking their hip this afternoon by a simple intervention such as an app tells me to read a policy about falls because that ward is known for falls, and I read that policy, as a result of which I take an action that reduces the risk of the fall and the fall doesn't happen.
Yeah.
I've saved literally hours and hours and hours of admin time and clinical time generating an incident report, doing a review, presenting the findings, let alone the patient who's had a broken hip.
Yeah, I think absolutely, and I think there's so many examples of this now. Looking at a shift tonight, we can absolutely know in any given area who's on shift.
Yeah,
we can see where somebody may have phoned in sick this morning.
Yeah.
We can see whether or not the skill mix is different to perhaps what the ideal skill mix would be. We can see whether or not we've got too much temporary staffing on there or people that have never worked in that area before, and then applying that knowledge about, well, in these circumstances historically, I don't know, medicines will typically be missed or misadministered. The ability to tap someone on the shoulder virtually and say, be aware, we've got you, just be careful. In a world where we don't have the ability to change the circumstances.
That's right.
Can't magic up more people.
Exactly.
You can't stop the fact that there's temporary staff on that shift.
Absolutely.
But what you need to do is make sure that you've got your arms around that team and you're giving them all the ability to see the danger.
Yeah.
That is absolutely within our gift.
Yeah, that is the core proposition, to, in real terms, in a practical sense, making things safer and of a higher quality.
Yeah.
Because that's what we should be aiming to do all the time. And all these small interventions, and they're small, if we just spend 5 minutes on that risk mitigation activity at the start of a shift, as you mentioned there, as I say, we're reducing hours and hours and hours of consequent time that would be spent investigating what went wrong.
Mm-hmm.
And if all those 5-minute interventions are scaled up, they're all quite small and quite manageable things to do. And I think what's sort of my take-home message, for once, for better expression, in the HFMA talk about job planning was, if we just collaborate with each other now to share the practical steps that people can take tomorrow, today, even in the moment, they can do something now when they go back to base, and when they get back to work, they can do something different that will stick and will make a difference. If we do that, tiny interventions will scale up, and that will absolutely reduce harm in the system.
Well, we're going to get as many of those tiny interventions showcased on this podcast. Can I ask you 2 quick questions?
Yeah.
Who's responsible for productivity?
Everyone.
Who's responsible for patient safety?
Everyone.
What is quality?
Well,
that was 3 questions. You're allowed to get out of this.
These aren't quick questions.
That was a joke. No,
these aren't quick
look,
questions.
Everyone, I think that's the message, isn't it?
It really is. And I think what's important is that everyone, whoever's listening to the podcast and all of us, whether you work in software, whether you work in healthcare, wherever you work, everything that you do in the day job is absolutely affecting the potential to improve safety and improve quality. And my closing reflection on this is you can actually have a high quality unsafe system. You can have a safe system that's of poor quality. They're not mutually exclusive, but thinking hard about how what you do all day in your job touches the ability of us to improve safety standards is the core thing that people should focus on every day when they get into work. And if we do that and think about practical, tiny things that they can do, or they can suggest, or they can share, that holds the key to everything else around it.
That is a great place to end this version of The Connection.
Yeah, it's been a great chat, and we hope you've enjoyed it.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.